Hi, good evening, good morning, good afternoon, everybody. It is 7 p.m. in Paris, 7 p.m. in Barcelona, 7 p.m. in Helsinki, 7 p.m. in Regensburg, 6 p.m. in London, 10 a.m. in San Francisco, and it is a great pleasure and honor to welcome you all to this new Journal Club broadcast by the International Academy for Clinical Hematology. I'm Mohamed Moti from the Saint Antoine Hospital and Sorbonne University in Paris, in France. And I'll be, as usual, moderating this Journal Club dedicated today to an article that has just been actually published a few days ago in the Lancet Hematology. And you can see the title here, Defibrotide plus best standard of care compared with best standard of care alone for the prevention of sinusoidal obstruction syndrome, Harmony, a randomized multi-center phase 3 trial. And during this discussion, you will see me using either SOS or VOD for veno-occlusive disease, which is historically the most common, widely used, I would say, acronym. And to discuss this paper, we have three top experts. One co-author of the article, Professor Selim Corbacioglu from the Regensburg University, is a pediatrician, and most importantly, he has led the previous phase 3 randomized trial on this topic, which was published in the Lancet actually more than 10 years ago, I believe in 2012. We have also two other panelists who are senior experts in this field of SOS VOD, namely Professor Enric Carreras from Barcelona and Professor Tapani Ruttu from Helsinki in Finland. And this is the abstract of the published trial. It's a state-of-the-art phase 3 trial, 104 centers, 14 countries, very international trial, including both adults and children, actually, who were considered either as a high-risk or very high-risk patient to develop VOD or SOS. And one group received the defibrotide at the usual standard dose of 25 milligram per kilo per day, and the control group received the best supportive care. And one important issue that we will be discussed, I guess, is that the primary endpoint was about the VOD SOS free survival at day 30 after transplant. And moreover, this is about being assessed by the independent endpoint adjudication committee in the intention to treat population. So you can see a very decent number of patients, 372 patients, median age 14, so we're rather more on the pediatric side, were randomized. But there was an IDMC meeting, Independent Data Monitoring Committee, which was planned for an interim analysis after the first 280 patients were recruited on the 29th of April, 2020. And unfortunately, the trial was stopped prematurely for presumed futility. And at the end of the day, at the final analysis, there were no differences between the two groups, and there were also no differences when it comes to side effects. So the first conclusion was that it is a negative trial where defibrotide did not show a benefit in the prophylaxis of VOD, and additional studies of carefully selected patients at high risk of VOD after transplant are warranted. And you can see here the VOD or SOS-free survival in the intention to treat population, the Kaplan-Meier estimate according to SOS as per investigator assessment at day 30. And why this issue of investigator is important, because you will see that there was some discrepancy between the independent committee assessment and the investigator assessment. And most importantly, the editor of the Lancet Hematology analysis was here, and I'm quoting, although the trial was negative, discrepancies in assessment of SOS between the independent adjudicators and the site investigators, even when using the same diagnostic criteria, highlight the challenges in diagnosing SOS. Due to the inclusion of the best supportive care group, this large randomized trial allowed evaluation of the safety profile of defibrotide versus best supportive care during the prophylactic treatment phase. And of course, all of this has implications because, and you can read it here, although the study was unsuccessful, we know, and this is what I mentioned in my introduction, that previous clinical evidence had supported the use of defibrotide for the prophylaxis of VOD in patients at high risk of disease after transplant. And of course, these are the important items that need to be discussed, because given the high mortality rate associated with SOS or VOD, more strategies on how to prevent development of VOD SOS are needed, especially in those high-risk patients. So I'll stop here. I would like to thank our panelists for joining us today. I thank all the loyal audience of the Journal Club. Please don't hesitate to send your questions, to post your comments or your suggestions. And I will start by seniority, and also usually I always start with the non-co-author. And by the way, as a disclaimer, I'm also a co-author of this paper. This is quite unique. Usually I try to avoid discussing or moderating those papers where I'm co-author, but this is how it happened today. So my first question is to you, Enric. Just before going into the details of the paper, just to explain to our audience what is VOD, especially what do we know today about the pathophysiology of VOD, and why we're doing all of these trials, actually.
In few words, because we have not many times, but we can say that VOD is the consequence of a multifactorial effects that results in the following events. First of all, it exists an accumulation of metabolites in the liver due to the metabolization of drugs used in the conditioning regimen. The most classical one is cyclophosphamide, no? It could be others. Under this condition, the normal conditions, these metabolites are converted in non-toxic metabolites, and then by the glutathione enzymatic system, and they are excreted without problems. But if this patient has received other drugs that reduce the enzymatic system of glutathione, like busulfan, BCNU, or TBI, or had a previous liver disease that reduced this enzymatic system, the toxic metabolites could accumulate in the zone 3 of the sinus. Remember, the zone 3 is the zone surrounding the central arterial veins. This zone is very rich in P415 and very poor in glutathione system. Then it produces in that place an injury of the hepatocytes and also in the sinusoidal endothelial cells. This injury is not only this one, it's completed by many others that we know very well. the cytokine storm produced by the conditioning, by the overactivity, by neutrophils implantation, the use of calcineurin inhibitors, especially some of them like sirolimus, the presence of lipopolysaccharides that cause the damaged intestinal barrier, or also other factors like endothelins, angiopoietin, and the activation of heparinases. But I mean, among others, all of them contribute to the final end. The final event is that these damaged endothelial cells round up like a balloon. And when they balloonize, they cause gaps. They cause openings between endothelial cells in the endothelial lining in the sinusoid. These gaps permits the passage of blood elements through the endothelial lining that pass through the space of these situated between the endothelial lining and the hepatocytes, and this produce a progressive detachment of the sinusoidal wall that progressively and concentrically occlude progressively the sinusoidal lumen and reduce progressively the microcirculation of the sinusoid. As at the end, this produces a complete obstruction. And these events leads to a post-sinusoidal hypertension and to the clinical manifestation of veno-occlusive disease. This is, in summary, the main events. Let me introduce a point on that because we have worked on that, only to comment that in our studies performed in vitro, we have demonstrated in our lab that the fibrotide, that is the objective of this paper, is able to normalize the endothelial dysfunction of these endothelial cells damaged by the conditioning regimen, is able to return to normality all the endothelial cells. This is an important thing in order to understand the role of the fibrotide. That's all.
Thank you very much, Enric, for these clear explanations. And by the way, I would like to acknowledge the hard work of your team and yourself over more, I think, than 30 years on this very specific topic, because we know very well the terrible outcome of VOD. And because it's a relatively rare complication, not many people were working on this topic. So here, maybe because you alluded, Enric, to the risk factors, so I'd like to ask Tapani about what are currently the risk factors for VOD? What is the incidence? Because you've been working recently on some survey on behalf of the EBMT about this topic, I think. Maybe if you can give us a brief summary about this, because then I'll ask Selim, get ready, Selim. We'll go to the paper about how the high risk and very high risk were defined in the paper, just to explain, because, you know, there are always subtle issues when we speak about the risk. And we have already questions from the audience about this.
Yeah, it's important to identify risk factors associated with this complication because it can affect the management of the patient, including VOD prophylaxis, the choice of transplantation method, and GVHD prophylaxis. And it can contribute to the assessment of the likelihood of developing a serious form of complication. And by the way, what I'm saying here is about adult patients. I have no experience with children, and we have high pediatric expertise in this panel. The picture in pediatric patients is different from adults. A large number of risk factors have been identified. They are very common, actually, and they can be transplant-related, patient and disease-related, or hepatic-related. The transplant-related risk factors include the use of donor with suboptimal tissue type match, including unrelated donor or HLA mismatched donor. High intensity of the pre-transplant conditioning is a risk factor, and some components of it increase the risk, such as 2 or more alkylating agents. And if the transplantation is a second one or a later one, the risk is increased. Patient and disease-related risk factors include older age, poor performance status, and advanced disease state. There can also be a genetic susceptibility to develop this complication. Hepatic-related risk factors include laboratory signs of liver injury, past history of hepatitis, cirrhosis, use of hepatotoxic drugs, particularly gemtuzumab or inotuzumab oxacamycin, and iron overload. The impact of the individual risk factors varies. Particularly important factors are older age, norethistérone treatment given to female patients, the oxacamycin-bound antibodies, pre-existing liver disease, and then, of course, some important pediatric diseases, but we'll hear more of them. It should be noticed that the role of risk factors can change with the development in the transplant procedures and technologies, as well as the patient materials, and the impact of individual factors may depend on the transplant setting. And many of these factors are unmodifiable. We cannot do anything about them, but some factors can be modified. For example, by the choice of the details of the transplant procedure, avoiding toxic components in the conditioning, or by the timing of the transplantation, for example, to allow for a reduction of iron load.
Okay, thank you very much, Tapani. So that is the global overview about the risk factors. So Selim, you contributed actively to this trial, and as highlighted by Tapani, you are a pediatrician, expert in this field. You led the previous positive trial about prophylaxis with the fibrotide. So maybe now we can dig a little bit deeper into the paper. And one question is about the definition of high risk versus very high risk in this trial, and how does it fit with our current practice? And we have a question, for instance, from the audience about stage 3 thalassemia, for instance, class 3 thalassemia, and how this would fit in the overall landscape.
Thank you, Mohammed. First of all, thank you for inviting me, and thank you for this excellent introduction to this paper. I think the situation with the risk factors is quite tricky. When we look at, for example, the inclusion criteria that were described in the paper for high-risk patients, one of the inclusion criteria is 2 alkylating agents or more, or 1 alkylating agent and TBI, for example, plus some hepatic damage that was not clearly defined. And there already the situation gets a little iffy, because, I mean, in the end, you run a prospective trial, you have a certain endpoint, you need to calculate a certain sample size based on the control group with a certain incidence of whatever you expect to affect. Now, things have changed in the last 10 years between this trial and the last trial. For example, when we ran the trial or when we designed the trial more than 15 years ago, we had basically little idea on the really high-risk criteria. We assumed high-risk criteria, but we were only confident when we completed the trial. We assumed an incidence of 25 to 30%, and based on that incidence, we calculated the sample size. Now, in the last 15 years, we changed a lot. We had high-resolution typing. We introduced triosulfan as a new alkylator. And in particular, with triosulfan, we see that there are substantial differences in the incidence of veno-occlusive disease compared, for example, to busulfan, in particular, without doing serum level measurements. So there are nice examples on the basically highest risk category that was also as high risk or very high risk category in this paper, patients with infantile malignant osteopetrosis. Historically, their incidence was 60%, but there's a publication by Shadur et al. A couple of years ago that used the more and more standard, at least in pediatrics, of fludarabine, treosulfan, and thiotepa, with an incidence of 0%, no mortality. So, combining two alkylators is not the proper approach to really identify the high-risk population, because combining fludarabine with treosulfan with thiotepa as two alkylators is not a predictor now per se as high incidence. So I think that's the issue. The other issue with high risk is compared to the pediatric prevention trial, as we know, the incidence in children is at least twice as high as in adults.
So just one interruption here, because we have a question from Dr. Ranjit Kumar asking why the children have a higher incidence of VOD while they have, like, I would say, a young and fit liver, nice hepatocytes, and I believe they didn't drink a lot of alcohol yet, and so on.
Yeah, I think the evidence is extremely clear that infants, and I'm talking about not really the proper definition of infants, but children and toddlers below the age of 2 years, are most probably the group with the highest risk of veno-occlusive disease. I mean, Strauss nicely summarized it. It's basically an exponential rise of incidence of veno-occlusive disease. And in that age range, VOD is not, or SOS is not a disease of post-transplant patients. It can be frequently observed in primary care with acute lymphoblastic leukemia or AML as well. And I think it is more or less the immaturity of the liver to metabolize these toxic agents that Enric nicely summarized in his introduction. So I think the age is, for me as a pediatrician, the most ominous predictor of veno-occlusive disease that strikes these children extremely frequently, particularly when you use high-dose chemotherapy.
Thank you very much, Selim. So it looks like it's a dynamic field, and it's good news that probably we are improving, as you said, because I'm well aware of the historical incidence in osteopetrosis, and now I can hear that it is decreasing. So now a question to all three of you, and I'll start again with Enric, and what is quite also weird, I think we had a remark from the audience, is to choose such a short-term primary endpoint, which is survival at day 30, because the comment from the colleague we have received is that these days, with good supportive care, with whatever complication, the probability of keeping patient alive at day 30 is extremely high, whether we're talking about VOD or anything else, which is true, because we have some very good ICU doctors now who are really can fight. So my question to all three of you, that despite these negative results, do you believe that there is still a need for VOD prophylaxis? And let's forget about the drug, which drug we're going to use, but the concept of trying to prevent this terrible complication. Enric.
For me, I'm absolutely sure about my answer. It should be necessary to have something to prevent this complication in the high-risk cases. I would like to add to the Selim words. Remember, after many years seeing patients with this complication, remember, it's not to have one risk factor or another risk factor. There is none. Is an addition of risk factors that is the risk for this patient. Remember that paper from the 90s showing that the risk factors are additive, and then the risk of VOD increase with the addition of risk factors. Then when you are a clinician and you are in front of one of these patients, you are sure if you could provide him a prophylaxis, you will be very happy. The problem is which prophylaxis. And as a consequence of that, it's very interesting to comment that I have reviewed a paper that should be published very soon, showing that many people is using yet the heparin for prophylaxis of veno-occlusive disease, and it works. And then that there are forms to prevent veno-occlusive is sure. For me, the example of the manuscript of Selim in Lancet 10 years ago is very clear. The difference is a perfect study, well designed, with a number of the patients of high risk, and the difference are very clear. And there are less patients with, but they are well selected high risk patients. Not only on that, there are had less patients with VOD, but in addition, less patients with GVHD. That is extremely interesting aspect, because all of them form parts of the endothelial damage of the transplant. Then if you could prevent this endothelial damage in the transplant, is very interesting. In addition, our studies in the lab show that the fibrotides, for example, prevent this damage. Then for me is very clear. And in addition, all the paper professional focused in patients, you can ask to any of them if they can, they provide prophylaxis to the high-risk patients, because they know that they will have problems. In adults, it could be a little bit different, because fortunately, the majority of patients have a non-severe VOD. And then, okay, it could be okay. That's another reason to explain what there is not sense to take the day 30 as survival data for analyze that, because many patients do not die at that time. They could have a big morbidity, but do not die. Then there is a nonsense objective to evaluate, but it was the study. I know was not there to criticize them.
No, I fully appreciate, but that's the importance of a journal club where we debate about the pro, the con, the positive, and the negative. We are in an academic discussion. And by the way, we discussed the risk factor, and we had a comment from Dr. Simone Cesaro, our friend from Italy, who was the past chairman of the infectious disease working party. Hi, Simone, who is mentioning that many centers no more use oral busulfan these days. Anyway, many centers are performing pharmacokinetics, and I think this is an important remark going in the same line of Selim's comment about the dynamic of the process. So Tapani, prevention, prophylaxis, how would you handle this today?
Not easy, because it is, I think, very
this
logical.
This is why we invited the experts, because if it was easy, we didn't need any.
I think it's very logical, even in adult patients. It's in children, it's even more clear. In adult patients, it's very logical that while we have these complications, which can be very severe, we should be able to identify them and then give prophylaxis. That's, I think, very logical. The problem is to identify the patients. And here in this study, it may not have been a success. And perhaps I want to comment on the risk structure of the patients in this study, because as far as I understood, the criteria were mild ablative conditioning and some liver problem as defined in the EBMT criteria. Now, there's a recent EBMT study which has been submitted for publication, where all the allogeneic transplant patients, adults, at 71 participating centers in the year 2018 were included in the study, and the incidence of VOD was 2.4%, which is much, much lower than what was used for the statistical calculations in this study. And therefore, the basis for the statistical power calculations for the study, I think, has to be asked, questioned, so to say. And as to the, coming back to the risk factors, the intensity of the conditioning, somewhat surprisingly, was quite similar among the patients receiving mild ablative conditioning as compared with those who got reduced intensity conditioning. There was practically no difference. And the hepatic risk factors, which was the other component in the study for the high risk, they are quite common as defined in the EBMT criteria, especially the iron overload, which is quite common, and the category of hepatic toxic drugs given to the patient at some time. So what I'm saying is that I'm not so convinced that these patients were, these adult patients were high risk patients, all of them. Some of course were, but in the average, the risk profile was not very high. So if we look at the incidence, which according to our study was very low, and the profile of the risk character, it's difficult to see what we really learned from the study. That's, if I continue, one point which has not been discussed here thus far is the criteria used for the diagnosis, the Seattle criteria. They may be fine for pediatric patients, but in adults, it is another question, because I think there's a rather general opinion that they are too non-stringent, and rather the bottom criteria or the EBD criteria should be used. The Seattle criteria are quite mild, and we should remember that according to the definition, when the criteria are fulfilled, VOD can be diagnosed unless the symptoms or signs are regarded as being caused by some other clinical condition. And this condition tends often to be forgotten. And in studies looking into this, quite a number or proportion of patients who fulfill the minimal criteria of the Seattle criteria are justly concluded to be caused by some other problem, such as GVHD, acute GVHD, or systemic infection. So the criteria on the adult side may not be optimal. The incidence calculations used are a little bit questionable, and the risk characteristics can also be discussed. So this is a difficult study to interpret. That's what I want to say in this phase.
No, I think you made a very important point, because obviously if you have a positive trial, you need to explain why it is positive and whether it is relevant clinically, but also we're doing the same exercise for a negative trial, trying to understand why the results were like this. And before moving to you, Selim, we have here a nice comment from Dr. Carmen Bonfim from Brazil. Hello, Carmen, and to all our Brazilian friends. It should be early afternoon or mid-afternoon for you in Brazil. And by the way, Dr. Bonfim gave a few months ago a very nice webinar on Fanconi anemia to the IACH, and she is writing that for some diseases, osteopetrosis, for example, there is a need for VOD prophylaxis we see VOD, I'm quoting her, in almost every baby transplanted with this disease. So for rare diseases, it will be difficult to get enough numbers to prove the efficacy of prophylaxis. So Selim, what is your take on the prevention issue and the comment we just had from Dr. Bonfim? We have another comment about inotuzumab. So inotuzumab treated patients have almost 50% probability of developing VOD, and most trials with inotuzumab still today recommend defibrotide for prevention. So what is your take on this?
Yeah, I think, first of all, we have, of course, the differences between adults and children. I mean, the incidence in adults is high, and I think we can, at this point, really very well define the high-risk population, which is and remains high-risk neuroblastoma, because it's a combination of a disease where the toxicity of the chemotherapy used is still extensive, and in particular in infants and small children. So you have at least two of the high-risk factors combined. Same might be true for osteopetrosis, where the osteoclasts are not working and you don't know really what their impact is in the liver. So these are the two diseases. The third disease is HLH, that remains a high-risk disease because of the inflammation that is going on, as we know, in this disease. So for children, I think it's easier with the prophylaxis. But as you know, the question is then, as it was mentioned many times, the criteria used. Right? So the incidences of the diseases are changing based on the criteria. Baltimore to Seattle, you basically double the incidence. Then Seattle to the pediatric prevention criteria, you raise the incidence a little more. Then there remains a gap between this very early intervention of the pediatric EBMT criteria, mainly triggered by refractory thrombocytopenia. And there's a question, is this gap to be filled with prophylaxis? And again, I would say in children, definitely yes. And as I mentioned, the high-risk population can be well defined. In adults, I fully agree that the ozogomycin conjugated monoclonal antibodies are an important and serious risk for veno-occlusive disease. And there will be a publication soon in the TCT journal, where they have an incidence of 30%, and the majority of those patients were patients with severe veno-occlusive disease, which is also very unusual, because coming back to the endpoint of this trial, which is another poorly methodological failure, as you said, was survival. And when you think of that, they had a sample size of approximately 400 patients calculated. But the endpoint was survival. Now, if we assume the incidence that we needed for the pediatric prevention trial with the presumed incidence of 20-25%, 360 patients were needed to demonstrate defibrotide prophylaxis is beneficial. Now, they used the same sample size. They had a mixed population of adult and children. So to hit that incidence is basically impossible, number one. And then the whole trial was basically killed by the endpoint survival. Because survival, as many of us, in particular, I think Enric mentioned, is a question in the high and very high-risk VOD population. So if we are generous and we expect a incidence or frequency of high and very high-risk VOD in approximately 25%, and we accept this generous incidence of 25% or 28% even that was used for this trial, you basically have to quadruple the sample size to have a power of the trial that demonstrates survival. So we're talking about 400 times 4, that's 1,600 patients. Yeah, and then we still have the issue of the IPAC with the discrepancy to the investigator incidence. That was basically hitting the nail on the head, where the incidence in the investigators setting was 16% in the control group and 12% in the defibrotide prevention group. So when you look back over the last years, that is exactly the incidence, 16% of a combined population of adults and children. very much on the point, which is very impressive, I would say, right? And this difference of 12 to 16, again, reflects the trend that you would have seen in a sample size, in a risk population that, if properly chosen, could have clearly confirmed the pediatric prevention trial. I think that's a major take on that. The incidence in the EPAC was, I think, 25% in the defibrotide arm and 21% in the control arm. That was an incidence that was not seen even 10 years ago in the high-risk pediatric prevention trial. I think there are major issues in this trial that were this journal club we have here today does not suffice to discuss. So I think that's the starting point to be critical about a trial. Just because it's prospective and randomized, it does not mean that it's good enough to prove the point here. So we have to go further into detail, and I'm happy to take.
No, thank you very much, Selim. I think you made some very robust points. I'll take a quick question from Dr. Maria Fusiova, because it looks like we still need prophylaxis, and the only available drug in the field of VOT is defibrotide, although it's not approved yet for prophylaxis. When do you start using it, before HCT or after HCT? My short answer is that we usually start at the time of when starting the conditioning. So here we have another comment. So because I think at this stage, it looks like there is an agreement that a negative trial like this one doesn't mean that we should not do anything anymore and VOD will just simply vanish. We know very well in routine practice that this is still a problem, although, and this is good news, this is not the majority of the patient. But maybe one option to move forward, and this is another comment from Dr. Cesaro from Italy, saying that GITMO, the Italian GITMO cooperative group, were running a trial, a study about the use of FibroScan and early diagnosis of VOD. So here, because it's a long comment, so to make a long story short, his comment is that the combination of very early diagnosis and immediate defibrotide treatment, not prevention, may allow to actually find a sort of a common denominator and reduce the risk of mortality and VOD. So what do you think about this sort of a preemptive or early anticipation, Enric?
This is a topic that we have commented many times. The preemptive treatment looks very well. No, it's not exactly the same concept that the preemptive in fungal infection, but it's similar. No, it should be at the minimum suspicion of veno-occlusive disease to start the complete treatment with the full doses and look the patient for 1, 2, 3 days, and it depending on the evolution, you stop or you continue. Is a position very realistic because you are adapting your view because you don't have many arms to act in front of that. You only have heparin or defibrotide, and then you have defibrotide and you use it very early. Remember, in addition, that all the papers on treatment on defibrotide show that the defibrotide started in the first 3 days have bad results that the defibrotide user later. Then it should be in the same sense, no? It should be to use that immediately when you suspect that. Is that a VOD? Stop defibrotide, no problem. But do not wait that the defibrotide becomes something, because I have no time to talk about that, but if you permit that the pathophysiology of veno-occlusive disease evolve, you arrive to situations of irreversible situations with fibrosis, etc., etc., etc. Then it should be treated early. Then
early intervention.
Exactly.
Early intervention is the keyword, and your message is very clear. And if it's not VOD, then you can still stop the treatment very quickly. Tapani, what is your view?
I fully agree. Preemptive treatment would be so to say easy solution because it's very logical, and you can, as said, stop it if your diagnosis is not right. But then you are on a very safe track anyway. I think people in practice do this, have done it for a long time. The early signs, start the treatment, although it has not perhaps been very correct, but that's in practice what's being done. And if you have early signs like this elastography and so on, it's a very good idea to start early.
I think Enric about the early intervention was alluding to the IND results, a very large study, more than 1,000 patients, showing that even a difference between 1 and 3 days can make a huge difference in the final outcome of the patient. Okay, we are running a little bit out of time. Usually in the Journal Club, the last word is for the
Mohammed.
Yes.
Let me mention something because it's in my mind, and I'm very nervous on that after analyzing carefully this paper. For me, the most surprising of this paper is not an inconclusive results, because the study is not well defined and not well prepared. For me, the more relevant thing is that the European Medicine Agency relied on finished and poorly designed study, decided do not recommend the use of defibrotide. This, for many people, means do not use it. And then I think it's incorrect because there is a lot of, especially pediatric patients, that could have clear benefits from its administration. Then I think the message, the immediate message based in this study, and why not with the previous one? The previous one randomized study was clearly effective. And then why they accept the second study as reason to do not recommend. For me, I'm not able to understand that.
No, I think it's an important, good point. And of course, we value the opinion of regulatory agencies, but obviously clinical judgment at the end, when you are in front of your patient, should prevail, in my opinion. And by the way, I think we had a comment, Enric, you mentioned low-dose heparin, and we had a comment saying that there is a meta-analysis showing that probably that's not highly effective, which I think we agree. Selim, what is your take-home message? Because you contributed actively to this, and you are a key player on a daily basis, I would say.
Yes, and I think I agree of course, with Enric with regards to early intervention. I think the important part here is a trigger. And at least in children, I mean, because we need some trigger to intervene early. And of course, we can stop early. We do that with viral titers. We treat viral titers with very toxic drugs, and then we stop treatment before the disease emerges because the titers are reducing. And I think with VOD, it's the same. Don't wait until Baltimore is eventually proven, because we know the hyperbilirubinemia is a late sign. Yes, it's high evidence, but it's a late sign. And we have a high incidence even in adult patients of anecdotic veno-occlusive disease, nicely shown in the treatment IND retrospective analysis. So I do a little publicity here for the pediatric prevention trial, looking at refractory thrombocytopenia that was not our invention, but it was already published in McDonald's original publication in '93, where he clearly described that symptom as an early predictor of veno-occlusive disease. So keep it at least in mind if you want to intervene early in a patient where you have the high suspicion of veno-occlusive disease, to at least consider VOD. Because when you consider it, you see it. It's like driving through Paris, you don't know the Tour Eiffel, you won't find it.
Well, excellent. Thank you very much. And you mentioned nicely Paris, and you know that in a few days, in 10 days actually, we'll have the EBMT annual meeting in Paris, and we would love to see you all there. And by the way, don't trust the media about, everything happening in France. Of course, there are some strikes and demonstrations, but we're still a very polite, very civilized country, no injuries, nothing bad is happening. So don't worry. The worst thing that can happen is that maybe your train can be delayed, guys, but that's not the end of the world. So here I'd like to thank you all for really a fantastic journal club. I think there was a consensus that a negative trial doesn't mean that the intervention should be forbidden. Same true for a positive trial, doesn't mean that everybody should get the intervention. And the devil is always in the details. And this is exactly what we try to dig a little bit deeper into the results of this important study. So with this, I'd like to thank you, Enric, thank you, Tapani, thank you, Selim, for your time and dedication to the field. And I'd like to thank our loyal audience for attending. And as you know, the ICH activities are really flourishing, because you may have seen that we will be launching soon the ICH for nurses, but there will be some other good news coming. So in the meantime, thank you all for joining, and wherever you are, please stay safe and keep well. Take care.
Bye-bye.
And see you soon. Bye.